Welcome to our third webinar. I am so pleased to see the number of attendees go up every time. So that's really very nice. Indeed, this is not just an educational project, but a project that joins two large continents, Latin America and Africa. And it's really amazing to see how the passion of treating venous diseases can join professionals on the two sides of the continents. This meeting is about non-thermal ablation. It's a very exciting topic, and what makes it most exciting are the speakers. We have two world-class speakers, Rahul Jindal from India and Professor Kursat Bozkurt from Turkey. Both have worldwide experience in these techniques. It's also my honor to present our esteemed panelists, and they will be presented in person later in the session. I'm delighted to present our guest of honor from Egypt, Professor Saeed Al-Mallah, who's going to be presented also in detail later in the session. I cannot proceed without thanking Professor Sergio Genassini, who's the real mastermind behind this great educational event, and to Dr. Wasila, who works day and night to bring this event the way it is now. I would like to announce once again about our award of $500 towards flight expenses plus free registration to VWinter, which is organized by the VWin Foundation, which will be held in Dubai in January 2022. The award will go to the best question or comment. All the questions and comments are being recorded and will be analyzed by a grand panel of world experts, and the winning question will be awarded this grant. I would like to also thank our sponsors, our main sponsor, Servier Daflon, our gold sponsor, Medtronic, our support sponsors, Abbott, Biolytic, and Promed, without whom this could not have been possible. Now I would like to give the word to Professor Robert Simkin, but I think he's still busy in the other seminar. Is he with us, Professor Simkin? Not yet. Well,
He's here, Robert.
Professor Simkin?
Yes, okay.
Professor Simkin, it's our honor to welcome you with us. Professor Simkin is Professor of Surgery, University of Buenos Aires. He's Director of the course of Vascular Surgery, Phlebology, and Lymphology. He's also General Secretary of the Latin American Venous Forum, and he's past President of the UIA. It's our honor to have you with us, Professor Simkin. Professor Simkin will speak in Spanish, and we have instant...
Speak Spanish or you prefer English? I prefer in English. All the session is in English, or you prefer in Spanish?
Whatever you wish. You go ahead.
English, okay. Thank you very much, Professor Rashad Bishara, and thank you very much all the people that invite me. That Professor Bishara give the good invitation for me to participate in this important meeting. When finish the meeting, I like to give one comment about the two topics that present the two exposition. The MOCA, Dr. Professor Rahul Jindal and Professor Ahmed Bozkurt will be present. The experience with the body clothes. The glue from Turkish is a very good glue that many people in all the world use in that moment. Thank you.
Professor Oscar Bottini, I don't think he's to join with us, so we'll give him the word a little later. And now I wish to present our first speaker. We all know Rahul Jindal. He's really world expert in MOCA. Of course, he's director of Kalidora Clinic and past president of the Venous Association of India and a member of the educational committee of the UIP. most important, I think he has one of the largest experiences worldwide in MOCA. Please, Professor Raboul, share your screen. Raboul, are you with us? Hello?
You need to stop. Yeah, I'm with you. You need to stop sharing. Then only I can share. Sorry. Yeah, it's okay. Done. Thank you. Can you see my screen, please?
Yes, Raboul, perfectly well, Raboul. Yes, perfectly well.
I'll start. Thank you, Professor Shad, and really, it's a great honor to speak in front of all of you. I'll just present a small experience with MOCA. We have been using this device from last 4 years. So I'll just share my experience. So we know the non-thermal techniques has been coming up in the last few years. And mainly what we have is a MOCA technique, glue, and the foam sclerotherapy. So foam glue is going to be taken up by a friend. Foam sclerotherapy we have been discussing quite a lot. So I'm going to concentrate on MOCA. MOCA is a mechanical occlusion of varicose veins. There are basically two devices. One from USA, another one is a Flebograph, which is from Poland. The basic difference between these two devices are Flebograph is a mechanical device. As you can see, there is no electrical component. Clarivan has got an electrical component, which makes the inner piece rotate at a very high speed. Flebograph, we use a foam, and in Clarivan, we use a liquid sclerosant. So that's the basic difference between these two devices. If you look into the word MOCA, that is patent by Clarivan. So actually talking technically, we cannot use a MOCA word for Flebograph, but there is an overlap between these two technologies. In terms of advantages, we all know it causes less pain, faster to perform, easy back to work, no tumescence anesthesia, and can be used below the knee long saphenous vein. But there are some disadvantages because SSV results are not clear. Treatment of big perforators cannot be performed, pigmentation, and long-term results more than 3 years we still don't have. Inclusion and exclusion criteria. So we did a lot of studies on this in last 4 years, and we included all the vein except patients with pregnancy, did not give consent, allergy to sclerosant, previous endovenous treatment of the vein, and huge SPJ junction. So let's talk about the technical aspects first. I'll use this an animation video the company. And at the time, you take the device. Once you've taken the device up, you open slowly remove the device. At the same time, you inject a foam sclerotherapy inside. So normally in 4 to 5 minutes to complete the whole procedure. So it's very quick as such. So let's take some live example. How do we do it? So this guy has got some varicose veins, long saphenous insufficiency. So this is how the kit comes in. So you got all the things, needle puncture, 18 gauge needle, 6 French sheath. You got a guide wire, which is around 90 centimeters. Then you got a Flebograph device, which is packed like this. So you take out this Flebograph from inside the catheter and you prepare it like this. So what you do is basically you take a heparinized line, you flush it from the side, then you close the hub, and then you push it again so that you can put in the heparin line throughout the catheter so that this line comes out at the tip. I'm just going to show you how the blade opens up inside. So you hold the catheter steady and you can see these 4 blades which comes out of the device there. And then you need to flush them again so that the device can slide very smoothly inside the vein. So once you flush this, then you close that and then you put it over the guide wire. So in the next step, what we are doing is here is we have put in under local anesthesia, 6 French sheath. We take the obturator out on the same guide wire. It's a 0.35 guide wire. So we put in the Flebograph device over top of it. So the advantage is, the tortuosity of the vein, it's not a problem at all. We have done few cases where there is a laser failure before. So we have used this device. There is, there is no problem as such. It doesn't get stuck up. So you take the device up at the SFTA junction, then there is no need for tumescence anesthesia. And then you pull up the device on an ultrasound. At the same time, you can put in a small pressure and you can see the device moving, and you follow certain protocol, which I'm going to share to you. And then you can inject a sclerosant. You can inject either an STD or a polyductal. You can inject 3% of foam made out of that inside the vein. So what's the difference between these two devices? Basically, they're quite, phlebography is quite simpler. Phlebograph in certain countries, they reuse it. So you can reuse, but Claravein, you can use it only once. So if you're using a bilateral varicose veins, so you cannot use Claravein because you have to use 2 Claraveins basically. And second is Claravein cannot be used in very small veins or a very big veins. So there is a problem with that. But as such, phlebograph can be used in all the sizes of the veins. In terms of results, we have got like 200 patients which were included in this study. Both SSVs and LSVs, 3% STD was used. All the varicosities in the legs were treated with the foam in the same sittings. So we follow this protocol. What we do is we open the blades at the SFTA junction, totally at the junction, and then we withdraw the blades up to 4 centimeters below the SFTA. So we scrap the first 4 centimeters off the vein also. Then you press on an ultrasound the SFTA junction, and then you inject 1.5 ml of 3% STD foam in the catheter. So because the volume, this is the amount of volume which you will require to fill in this catheter. And we try to have a very limited blood into the catheter, because that's why we don't take the wire out unless I'm ready with the injection. So it may require around 0.5 ml more foam sometimes if the vein at the top is quite big. So then we inject 0.5 ml of foam every 4 centimeters up to the black mark of the catheter. Then at the end, I remove the sheath, and around 2 centimeters sheath, I keep it inside so that I don't injure the skin entry point with the blades. And then you take the blades inside the sheath and you remove them altogether. If you look into our initial results, the technical and clinical success was very good. Really, it's a very, very simple procedure. And if you look into the complication in terms, it's very minimal complications. Patients don't feel much pain. And especially I found, which was very different from laser and RF, was that in the post-operative patient don't complain of that stiffness in the thigh, which you get with all the thermal techniques. And if you look into the follow-up at 2 years, we have around 8% failure. And so we got 92% closure, which was there. In terms of, if you look into this publication, which I read few years back, a Maradona trial, which compared the radio frequency with the MoCA, and they showed that MoCA has got less pain, but there were little drawbacks with this study. And in our clinical practice, we see, different patients have got different pain threshold. Sometimes I see do a thermal ablation, the VAS pain score is 80, 8, and in some it's 0. So we came to a conclusion that the pain perception in a person is not basically on the technique, it's also the age and the psychology of the patient. I came to one of these studies from NIH, that why do some people tolerate pain better than the found matter in your brain when you get more. So in the future, you can see if your patients are complaining of a lot of pain, so what's the problem? So on this basis, we defined a study and a hypothesis that different patient subsets have different pain thresholds. So how you can compare, if you are going to do the study in different patients. So what we did, we took 100 patients with bilateral varicose veins and a single center, single operator, so removed all the bias. And in one leg, we did an RF ablation, and in one leg, we did a MoCA, and then we did all the follow-up with the anatomical success, clinical success, and the pain. So we are going to publish this study soon now. It was all the patients were done in a walk-in procedure under local anesthesia, standard technique with RF. We have already described you the standard technique, what we did, and we discharged the patient in 1 hour with compression. And we followed up 75 patients, the 25 patients, we could not do it at 1 year follow-up. And technical clinical success was absolutely equal. And when you look into the pain aspect, intraoperatively, patient used to feel more pain with tumescence rather than with the RF. And post-operatively, there was no difference in pain frequency and MoCA. So actually thermal techniques did not cause you more pain than MoCA. And if you looked into the complications, there were more bruise with the thermal techniques, right? But as such, there's not much difference in the complications you later on. And when we followed them up at 1 year, we found that MoCA has got 94% rate and frequency has 97% closure rate with this technique. And let's look at the literature. There have been a lot of literature which has been published in this year. There were very few studies which were published before. So let's started from 2016 up to September 2020. So let's see 2016 study, 300 patients, 3.3% failure rate, and the device used for Claravin, and the follow-up was only 2 months. So this study is out of syllabus because only 2 months follow-up. It's of no use to me. Then a JVS published a meta-analysis on 2017 with all the published results. If you go in detail, it shows that here occlusion rate is 96, 97%. But there are a lot of studies which has got a lot of drawbacks. So I would really take this data with salt. Then another with surgery, the LAMA trial, comparing the laser with a MOC device. We used the device Claravin in this. But what you saw, the follow-up only for 1 year. And failure rate, you see the success rate with MoCA was 77% only. And the laser was 91%. So you see, there is a drawback. I think, I really don't know the operators, but 91% with laser at 1 year, I will not accept it in 2020 because laser at 1 year now goes up to 98% success rate. So there is 7% failure in the laser also. Another Italian experience in April 2020 published. This is the longest follow-up published in the world up to now. It's a 5 years follow-up with the Claravin with 2% polydocanol. So they have changed the constituent of the polydocanol, and they found the technical success was good, everything was good. But at 5 years, the success rate is 84%. So which is quite good as such if we believe everything is right in this study. Then another study published in 2020 April with Claravin again. Follow-up is 1 year. The success is 84% only. Another technique published with Flebograph, 2020 August. I really doesn't need to be included in the study because this is only 3 months follow-up. So, it's not was as such because you really need a long-term follow-up. Another study published from Egypt, laser ablation versus MoCA, a randomized clinical trial, but 100 patients were followed up, but there were no anatomical closure rates published. So all the studies followed up for 1 year follow-up were only symptoms were compared, but there was no ultrasound comparison that how many veins opened up on the follow-up. Then in the study published and used 2% polydocanol with the MoCA device and 1 year occlusion rates were 92. So this study actually has got a nearly similar results as to our study. MoCA has a success shorter results. I think symptomatic improvement at 2 to 3 years is similar to thermal ablation in a lot of studies. Anatomical success rate really varies in different studies and definitely are poorer than the thermal methods. And I think this technique has got a subset of patients where it should be preferred, like an obese patients where patient has got needle phobia, a lack of infrastructure like laser machines and TIMISN facilities. And this can be really taught very easily to the people. And I think these are the sort of group where this technique has got a place. Thank you.
Thank you, Dr. Rahul, for sharing your experience with us and for giving us a good summary of the literature. Now, Dr. Osila, please present the panelists. Dr. Osila?
Yes, Dr. Rashad, I'm here. Yes, confirm that you hear me. Can you hear me?
Yes.
Yes, all right. Welcome everybody to our third night, Saturday night vein talk. Before introducing the panels, I wish to congratulate our dear friend Rahul Jindal for such excellent presentation, compiling all the literature about MOCA. Thank you, Rahul, for your effort and your support. Thank you. And now I'm truly honored to introduce Professor Tomasz Urbanek from Poland. Professor Urbanek is the consultant vascular surgeon, president of Polish Society of Phlebology, member of the European Venous Forum, member of the American Venous and Lymphatic Society, member of organizing committee of the European HOWIN Plus, and Congress President of the UIP chapter meeting Krakow, August 2019. And it was really a spectacular meeting in terms of top-notch scientific lectures, outstanding workshops, and really phenomenal hospitality. Thank you very much, Thomas. And now the podium is yours to deliver your question for Dr. Rahul Jindal. Thomas, please.
Thank you very much for this kind invitation and introduction. As we don't have much time, as far I know. Rahul, I wanted to ask you, I mean, just one short comment about the compression of the saphenous ostium when doing MOCA. I do not see any special reason if doing this by phlebograph. Personally, in my practice, I never do this. Second, and this is my question, what about the vein size? Because you suggest that we can use this method in a wide spectrum of the pathologies concerning the saphenous vein. I think that doing this procedure in the small veins, like 4 or 5 millimeters, makes this procedure very complex, sometimes difficult to perform, and because of spasm, even impossible in many cases. And it's more painful in very, very small veins below 4 millimeters. And if we speak about large veins, we do not have data about the efficacy in the veins like 15 millimeters. And the company advised this to use this device up till 12 millimeters. The size between the hooks is 27 millimeters, but I stop usually using this device at the level of 10, maximum 12 millimeters. We don't have data about the large veins. Thank you.
Yeah, absolutely. I think there are very important questions. A lot of questions has come up into this. One is when we started using it, and when we wanted to do this procedure in the studies, we wanted to include all coming patients because we didn't have the follow-up, we didn't have the published studies with phlebograph device, and I'm talking about 4 or 5 years back. And what we found that most of the failures, what we had, they were all in the bigger veins, and all or the patients which we treated in the post-thrombotic veins. So these were the two subgroup of patients we found which has got more failure. So in my practice, so now I don't use phlebograph if the patient has got a post-thrombotic SFJ incompetence. Second, I don't use it if the vein is more than 10 millimeter veins, as you have already mentioned in your question. And because I feel that if the vein is very big, if the vein is post-thrombotic, then the results are not good. These veins, they open up later on.
Thank you very much. I think there will be new studies coming in Poland. We conduct right now the multi-center study on the phlebograph with 2 years follow-up, and we recruited 170 patients up till now. So new studies will be available. Thank you. Thank you very much.
Great. That would be nice. Thank you.
Dr. Asila, would you like to present Dr. Wael Shaalan, please?
Yes, I'm truly honored to introduce Professor Wael Shaalan. He's a professor of vascular surgery at Alexandria University, consultant of vascular surgery at AVC, associate member of EVLA. And his last achievement was really great. Maybe it was the last in-person vascular meeting on this planet in March 2020. Professor Wael Shaalan, the podium is yours now.
Good evening, everyone. First, I would like to thank Dr. Rashad, Dr. Asila for the kind invitation and the nice introduction, and for your efforts arranging such respectful webinars. Congratulations, Dr. Rahul, for your illustrated presentation. My question is, having many options in the endovenous toolbox for varicose vein ablation. So if you were to choose between radiofrequency, laser, MOCA, and glue, what do you choose and why? In other words, are there any indications or factors that help choose among the different techniques, or it's only related to the surgeon's preference and local expertise? The second part of my question is, what about the long-term occlusion rate and the recurrence at 3 and 5 years, especially if we compare this to the gold standard, which is stripping, does it affect your decision making or not?
Okay, there are a lot of questions. I'll try to answer them in a simpler way. The first part, what technique I use.
Yes.
You see, if you ask me if I, a lot of people come for us for training, I tell them if you have to choose one technique, then choose laser first. Okay,
Right.
there are a lot of reasons for that. If you have to buy the first machine in your center, if you're just starting to do the practice, you take the laser. The reason for that is because it's very versatile. You can close from 4 millimeters to 22 millimeter vein, and you can burn post-thrombotic veins with a very thick walls. You can do 1 centimeter stump. You can burn because you can do the punctures. You can do the perforator with the bare fibers, and there are a lot of fibers which you can attach. You can use the same machine for
It's a bad connection.
Yeah.
Dr. Raoul, we can't hear you anymore.
We lost you, Dr. Raoul.
We lost you.
So the answer was laser.
Shad, do you want to go on with the questions from the audience and we ask the
Yes,
panelists to
please.
answer while we are waiting?
Yes, please go ahead, Serge, please.
Okay, so I have the honor of reading the questions from the audience, and as you know, we always pick up the ones who are getting more likes, and I remind all of you that all the questions are eligible for winning the award independently by the age of the person who's making the question. And if the age is over 35, the winner will give simply the award to the ones who are younger than 35. The first question is coming on the way from Venezuela, from our friend Hugo Navas. And is addressed basically, Thomas, I would go with you while we are waiting for Raoul. Can you hear me, Thomas, well?
Yes, I hear you.
Yes, it's again about the caliber, and he was expanding the question about on the non-thermal techniques. And since we have also Professor Bozkurt with us, I would say that the two of you are the perfect ones to answer this question about the caliber in non-thermal. So, Thomas, what is your vision about the other techniques and the one of Professor Bozkurt?
MoCA and Phlebogryph, I think there are good methods for the small and medium-sized veins, but as I mentioned, I will not use this for very small veins. Usually, if we have these patients with the veins like up till 8 millimeters, probably does not matter much, but if the veins are above the 8 millimeters, I see the difference, and then I'm choosing mostly the thermal methods. However, if patient cannot afford, Phlebogryph is an option for the patient up till 12 millimeters. If this is really above, I would never use this technique.
Kursat, can you comment on your experience? You are muted, Kursat. Can you mute yourself?
First of all, thanks for the invitation. Certainly, every doctor dealing with this endovenous ablation business should have 2 devices in the hand. One should be thermal, the other one should be non-thermal. I believe 12 to 13 millimeters should be the upper limit for non-thermal techniques. It's same for glue. I mean, if you like to treat over 14 millimeters, I mean, you may be in a bad results. That's why I prefer, if the size of the vein is over 14, I just go to the radiofrequency ablation, one of the thermal techniques. But depends on the circumstances. For example, if the vein is 10, 12, if the patient wants to have non-thermal, I just go to the glue. I don't have any experience with MoCA. I don't have any experience with Phlebogryph. Actually, I wish to use. But definitely both of the techniques should be available, and the surgeon should choose one of them.
Thank you, Kursat and Thomas, and Hugo Navas from Venezuela. Rashad, would you like to go on, or would you like to? You're muted.
Maybe one more question, maybe, Dr. Rashad.
One more question. Sir.
One more question.
So I see that Raoul is back with us. Can you hear nicely, Raoul?
Yes, I can hear you. All the discussions, what you're going on.
Yeah, you have been saved by 2 great nights, I would say. So we have now Mohamed Youssef asking if the technique is suitable for incompetent perforators.
You see, this technique is, you cannot put in this device into the perforator, as you could see from the technical aspect. Yes, if there are smaller perforator, if you're going to occlude the main vein, and if these perforators are joining into the main vein, then of course, if you occlude the main vein, that the reflux for the perforators will get closed anyway. And some people have used this device actually from the ankle also. And I don't like to use it, but some people have used it. And so you put into the ankle and run the device from the top up to the bottom, and all the perforators, if they are there in between, then it will close. But if, in my personal experience, this device cannot be put in directly into the perforator. So if you have a very big perforator in between, then it's better to go close the perforator directly with the laser, and then you can run the device through, you know, if you want to use flebogrip. But otherwise, you can just do the laser throughout.
And I will briefly mention also the question of Niad Fawad, who is asking about the incidence of DVT and P. Just to drop a question, like an open question, about this COVID time, the thrombotic tendency our patients can have, and what we consider the best technique eventually in this thrombotic time. Could you comment on this, Raul?
Yeah, definitely. You know, we are seeing patients like in our hospital, 60% of the occupancy of the hospital with the COVID positive patients now. And every day we are getting one call with thrombosis, arterial or venous now. I personally feel that if the patient is COVID positive, then of course you're not going to operate that patient. You're not going, because varicose vein is not an emergency procedure. So you're going to wait for the inflammation of the body to go down. And once, if the patient is COVID negative, then you're going to follow the same precautions as you do in general. You're going to give the anticoagulation only in the high risk group of patients. And once the inflammation for the post-COVID settles down, and now there are a lot of literature which has shown that 14 to 28 days later, post-COVID, all the inflammation nearly becomes zero. So post 1 month of COVID, we have done 3 patients now. Post 1 month COVID positive, who have become negative, we have done the varicose veins. So we are not giving any extra anticoagulations. We are treating them as like a normal patients.
Thank you, Rahul.
Thank you.
Oscar, would you like to present Dr. Shantanu Kumar, please?
Thank you, sir, for your very nice presentation. I'm very lucky that I had the opportunity to work with you at your place. So I had 2 questions. The first question is whether when you are using, do you have any experience of doing both MoCA and laser or RF simultaneously in the same patient? And what is the results? And another question is, as you are not using any tumescent, and so how much pressure you put over the veins to collapse it at the saphenofemoral junction? Thank you.
Did you hear? Did you understand the question?
Already in my presentation, so we have done like 100. Yeah, I understood the. Sorry, I understood. Can you hear me now?
Yes.
Hello. Yeah.
Bit interrupted.
Can you hear me?
No, the connection is not very well, Rabu.
Okay. Yeah, I know. I'm in the hills, so that's why the connection is not very good. Can you hear me now, or not?
Yes,
Yes, we can hear you.
Yeah. So the first part of the question I've already answered that in my presentation. So we have done 100 patients with bilateral varicose veins. So where we have done the RF in one leg and the laser in one leg, as you could see from the presentation. And so the results I've already mentioned at 1 year. The MoCA has around 94% and the RF has around 98%. The second part of the question is how much you press at the saphenofemoral junction. You see, even the probe pressure, if you just hold the probe, that, you know, and you put it gently down, because depending upon the patient is thin or fat. If the patient is very thin, if you just hold the probe down, it compresses SFJ. But if the patient is fat, you just need to press it a little bit. You see, why we do this is, if we work on the principle of that the foam reacts in that position only. I compress the SFJ junction and then inject the foam, and I want to make sure that the foam stays in that first 4 centimeters of my vein. And I hold that probe and wait for 10 seconds for the foam to act there. because if you just don't press the junction and you inject the foam, all the foam actually just goes into the deep vein. You see it on ultrasound, and the foam does not stay at SFJ junction. And if you look into the SFJ junction, that's quite big. So how will the foam will close that junction? So that's my theory of that. I press the junction, inject the foam, and wait for another 20 seconds at least for the foam to act there, and and then go down.
Thank you, Dr. Abur. And now Dr. Wasila has a little surprise for us. Go ahead, Dr. Wasila, please.
Okay, thank you, Dr. Rashad. Here is the surprise. We celebrate today the birthday of our dear colleague from Turkey, Dr. Suad Dogenci.
Very nice.
Dr. Suad Dogenci, happy birthday. Iki Duden. It took me 1 hour to say it. Iki Duden. Please, Dr. Kurshat, correct me if I'm wrong. Iki Duden Suad Dogenci. Happy birthday, dear.
It's good. It was good. It was
Thank
good.
You. Thank you.
You learned Turkish. Already learned Turkish.
Thank you, Kurshat.
And now we will move to the second part of the meeting. It's my great pleasure and honor to present Professor Kursat Bozkurt. I hope I'm pronouncing the name correctly. He's Professor of Cardiovascular Surgery at Istanbul University, and he's really one of the world's largest experiences in Turkish glue. Professor Bozkurt, go ahead.
Thank you. Again, the same problems with this program. Is it possible to show my slides?
Yeah, share your screen, please.
Yeah, I did. Again, for some reason, it's not working in this program. I think the techniques have my slides there.
Khaled, maybe.
Yes,
can
we
you
have.
See now?
Now we can see your slides, Dr. Kursat.
Good. Good?
Yes, perfectly well.
Good, thank you. Right, actually the topic you gave me today is there a difference between various glues? By the way, this is really a dangerous subject to speak. Actually, if you are talking about cyanoacrylate glue, it's not a new stuff. It is in chemical use, in medical use for 40, 50 years. Americans started to use this material in the Korean War for closing of the wounds, and then for example, brain aneurysmatic dilatation, and in some occasions. There are currently 3 available glues in the world. The first and original one is Venasil, which is Medtronic. Then we had, as a second one, very close. Then finally we have Invamed, Venabloc glue. I heard some of the companies from India, they started to produce glue, but I'm not sure they had the approval or not. But I heard about it. But at least in my knowledge, there are only 3 available glues who had CE mark in the world are these 3. Right, this is very important and very crucial slide I want to show to you. First of all, what are the differences between 3 glues? Venasil, Variclose, and Venabloc. First of all, polymerization time. Venasil has the longest polymerization time, which is almost 100 and over 100 seconds. And Variclose and Venabloc has short, only 5 seconds. really the action is quite fast in both of the Turkish glues, both Variclose and Venabloc. In theory, Variclose and Venabloc has almost the same chemical ingredients. Regarding the viscosity, Venacil is honey-like, and Variclose and Venabloc has water-like. It's very easy to inject, to use Variclose and Venabloc in comparison to Venacil. The application is different. Venacil is using a standard Serlinger technique. If we use Venacil, we are using a long introducer, guide wire, and everything. It's same for Variclose. Variclose has the same introducing kit like Venacil, but Venabloc is different. Venabloc is the last one. It's like radiofrequency catheter. We are not using a standard typical long introducers, long Sandiger wires here. We are using only 6F introducer, and from the 6F introducer, we are introducing the catheter. Usually it makes life more practical, more easier, but the disadvantage is in some tortuous veins, it might be difficult to introduce Venabloc, because when you are using Venacil or Variclose, because of the very long guide wire, J wire, you may able to pass the difficult angles better. Procedure time is longer in Venacil because you are pushing some glue inside, waiting and other stuff. But if you are using Variclose or Venabloc, it's a continuous technique. We are just pulling it back. And in 4 or 5 minutes, you can easily close the vein. It's really very short procedure. There's one disadvantage, very important disadvantage of Variclose and Venabloc. If, as the polymerization time is quite fast, the possibility of catheter occlusion is bigger than the Venacil one. The reason is, if you are not enough experienced person, and if you wait long time when the catheter in the body, there's a big possibility of blockage. That's why for a new beginners, sometimes it might be painful. The other disadvantage of Turkish glue is, again, because of the very quick polymerization time, bilateral usage, for example, both Venacil and Magna, may not be practical with using Turkish glue. But for Venacil, yes, you can use. Sometimes what I am doing is, I'm flushing the catheter with 10% dextrose, and I may do bilateral application with Turkish glue as well. But if you flush the catheter with saline, you may not have the chance. Sometimes it works, but practically speaking, I'm not using one Turkish glue for 2 legs. One package for one leg, the other package is the other leg. I'm going to explain you later, but long stump is a possible danger for the future of this procedure. The reason is we may have higher recurrence rate because of the long stump after the procedure. If you are using Venacil, company suggests you have to be away 5 centimeters from the saphenofemoral junction. That means you are leaving 5 centimeters gap in the saphenofemoral junction, and it may cause in future anterior accessory saphenous vein recurrences. But if you are using Variclose or Venabloc, I like to be very close to the saphenofemoral junction. I'm talking about even 2 centimeters. And in that case, you are doing almost a flash occlusion. And in theory, at least in theory, you may not have a lot of recurrences. It's one disadvantage of Turkish glue because of the chemical ingredients. Venacil is flexible, more flexible. Variclose and Venabloc is very firm. You can easily feel the Variclose of Venabloc below the skin if you are using it in the extrafacial area. With Venacil, it may not possible to use perforative ablation because of the polymerization time. I did a lot of perforating ablation with varicose. It really works nice, very nice. I will show you the picture later. With Venabloc, in theory, you can use, but if I do perforating ablation, I just use varicose. It works better. What about this kind of scientific data? If we evaluate the scientific data of Turkish glue, this is the paper we published in 2016, and the quality of the paper was rated as 19. It's not very good, but if we review the data of Morrison V-Class study, it's 23. The Venasil data are stronger, I have to admit. The reason is it's company-sponsored long-term studies. In comparison to the Turkish glue data, it's stronger. The quality of the control is better than our data. But at the end of the day, Turkish glue also has 19 points for the security of the data. This is an important subject to evaluate. And this is the first data published in the World Literature, V-Close trial back to 2015, and which shows good data for closure. Then we know 5 years data of V-Close trial. As you can see here, after 5 years of the procedure, the Venasil still has over 90% closure rate, which is quite satisfying results. And the V-Close data was published first in 2015. Then in 2016, we published the first data with Turkish glue, almost the same protocol. We compared with laser, not radiofrequency. And our data are also very strong, and which also shows very good results. We are now preparing our 5 years data, and it's going to be published in UIP Istanbul meeting. We have another published data with Turkish glue, which was in 2017, which was published in Journal of Vascular Surgery, almost same closure rates. We are talking about 98% closure rates with using Turkish glue without any important side effects. This is a meta-analysis of the very close Turkish glue, 1,000 limbs, and 30 months closure rate is 94%, quite secure. And we have another 2 years data with using Turkish glue, again, very long follow-up. But as you can see here, with Turkish data, we don't have published data after 2.5 years with this one. And our paper will be published, actually will be presented next year in UIP meeting. This is another Turkish glue, which one is Venabloc. Venabloc is different than Venasil, Venasil and very close. And 2 years follow-up show over 99% closure rate with using it. And as a meta-analysis, definitely 3 different glues are working very nice in comparison to thermal ablation methods. And because of this, in the recent, which was published last year, European College of Phlebology guideline, we suggested glue as 2AA recommendation, 2AA recommendation. But now I'd like to talk something about some drawbacks of different glues, allergic problems, granuloma, long stump, and permanent chemical candidate. I just want to touch some of the literature regarding these problems. Venasil published the hypersensitivity reactions with using glue. And as you can see here, hypersensitive reactions occurred almost 6% of the patients with glue. Certainly, we do also have some hypersensitive reactions with Turkish glue, but definitely not as high as like that. I don't know why, possibly it's maybe underreporting, or maybe the chemical differences between two glues. But at the end of the day, whatever you use, whether Turkish glues or Venasil, you have a possibility of hypersensitivity reactions to cyanoacrylate. I mean, we have to accept it. This is one recent paper published in a paper, Persistent Type 4 Hypersensitivity after cyanoacrylate closure. And at the end, the authors had to resect the saphenous vein. And here you can see the glue. This is an unfortunate patient, and they had to resect the vein with big incisions. So, definitely, it's not a good idea for an aesthetic procedure, and it's a problem. Another glue rejection after Venasil application, it is also a possibility. So allergic problems, it's a concern when we are using glue application. The second important thing might be very important in the future use is a long stump. I mean, when we are using laser or radiofrequency ablation, as you can see, we leave very small segment of stump here, maybe 5 millimeters, that's it. But if we use glue, usually we like to leave 3 to 5 centimeters gap here, and it might be a future reason for anterior exterior saphenous vein occurrence. If you use Venasil, it's long, but for Turkish glue, because of the good polymerization time, the possibility of deep vein thrombosis is lower. That's why you may go closer to the saphenofemoral junction. And I believe this is an important advantage for future use of the glue application. At the end of the day, these are permanent chemical content. Nobody can say some sort of absorption of the glue after some stage. This is a patient in my follow-up. It's not one of my cases. This patient had the procedures 4 years ago in another hospital. It was a short saphenous vein treatment, and unfortunately the glue sits in the popliteal vein. I haven't done anything for these patients. I just put him on apixaban, and now he's on apixaban treatment. He's totally symptom-free, but this picture is 4 years after the procedure, and you can see here easily, it's still there. 4 years ago, the size of the glue was 118, and still this vein, the size of the vein is 118. It stays there. That's why if you are thinking to use glue, you have to understand this is a permanent stuff in the body. Another important advantage of Turkish glue, and specifically very close, is you can use it in perforating veins. Recently, I'm treating all of the perforating vein with glue ablation. I used to use foam, I used to use laser, but believe me, for perforating vein ablation, specifically quick acting Turkish glue is doing very good job. It's same for long stump closure after endovenous ablation or stripping procedures. In this country, the general surgeons used to do a lot of strippings, and they used to do a big stump in the saphenofemoral junction. And this open segment is very important reason for recurrences, and you can easily close that area with glue. This is an example for perforating vein ablation, very easy procedure, and you can just put a tip of the catheter there, and you can easily close it. It's same for recurrent truncal reflux after thermal ablation. And finally, this is the final recommendations of interventional angiology, and cyanoacrylate glue is 1B recommendation and waiting for long-term results. We still don't have 5 years data for Turkish glue, and we are waiting this one. And finally, I want to invite you to UIP Istanbul World Meeting and also European Society of Vascular Surgery meeting in 2023. Thanks again for this wonderful invitation.
Thank you, Professor Bozkurt, for sharing your large experience, and thank you for sharing this very important information. Now, Dr. Wasila will present our esteemed panelist for the second presentation. Please go ahead.
Yes, Dr. Rashad, but not before to congratulate Professor Kurshad. You did cover very well the topic from every aspect, Dr. Kurshad. Thank you very much. And I think it will stimulate a lot of interesting questions, and we have a lot of questions already in the questions and answer box. Thank you, Dr. Kurshad. Now I'm truly honored to introduce Professor Elena Goranova. Professor Elena Goranova, she's a vascular surgeon and president of the Bulgarian Society of Phlebology, consultant at the Medical Center of Alexandrosovska, and she is Francophone, and she is proud to be Francophone. And this is, I do agree with you, Elena, le français est une très belle langue. Professor Elena Goranova, the podium is yours now to deliver your question to Professor Bozkurt. Please, Elena. Unmute yourself, Elena. Unmute.
Hello, Wasila.
Hello, Elena.
Je vous remercie beaucoup pour cette présentation.
L'honneur est le nôtre. Hein? C'est un grand plaisir de vous avoir reçu ici en Égypte.
Thank
Allez,
you. Just a little remark. I am president of the Balkan Venus Forum.
Okay.
It is a forum of Balkan countries, different countries, about 10 or 11.
So you have to be in another webinar, next webinar, to correct this title, okay? Allez-y, s'il vous plaît, allez-y, Elena.
Professor Bishar, for your kind invitation. It is an honor for me to be here. Dear Professor Bozkurt, you are well known with your large-scale vena block glue experience. I would like to ask you, what is the maximum quantity of glue that you would inject in a widest or largest vein having more than 15 millimeters of diameter, or in presence of a huge varix near the saphenofemoral junction? Consequently, how do you proceed in case of you observe a mass of glue penetrating in the femoral vein? Thank you.
Starting from the second question, fortunately, so far I haven't seen any glue in the femoral vein or towards the femoral vein. I'm very careful. I'm blocking the saphenofemoral junction very carefully, and I haven't seen any problem there. But in our country, now in my follow-up, there are two patients. One of them is the glue in the popliteal vein, and the other patient is in the iliac vein. Yes, there is one patient. In this patient, the glue unfortunately migrated to the iliac vein. In both patients, we are not doing anything. We just leave them alone. We put them on anticoagulation treatment, and then they are doing well. But I mean, in our country, we don't have any patient who had the procedure to taking out the vein. But I mean, if necessary, we are all surgeons, if necessary, and if the vein is blocked and if the leg is very swollen, we may have to open the vein, resect the glue, and put a graft maybe there, a short segment graft. But I haven't seen such a problem so far. Regarding the second question, the maximum amount of glue I used so far is 2 mils. 2 mils, only 2 mils. It's enough for almost all patients. I mean, you are just injecting a bigger amount to the saphenofemoral junction, and after that, you are just giving continuous application. So I believe 2 mils of cyanoacrylate glue is enough for almost all patients. Maybe you know, actually the glue itself is not filling all of the vein. The glue is causing a very active reaction, inflammatory reaction there, and a complex thrombus, including blood, glue, causing the vein. So that's why 2 mils is enough for almost all patients. Usually, actually, not 2 meals. 1.2, 1.3 meals is enough for the normal venous vena magna.
Thank you, Dr. Goranova. Very important question. I'm afraid we cannot allow more questions for the sake of time. Dr. Rosila, could you please present our African panelist?
Yes, Dr. Rashad. Now we are really honored to have such an important part of our African segment of LATAF webinars. We have with us, among us today, Professor Ahmed Frikha from Tunisia. And Professor Frikha, he's the big icon of the vascular surgery in Tunisia and all the North Africa. He is the chief of cardiothoracic and vascular surgery department in Sfax and president of Tunisian Cardiothoracic Vascular Surgery Association from 2015 to 2017, member of Tunisian Vascular Medicine Society, member of the European Cardiac Surgery Society, and president of the CV3S, Cardiovascular Surgery Symposium in Sfax. Professor Ahmed Frikha, you will deliver your question in French and I will do the translation if you wish, and we have the video as you wish. Now we have...
D'abord, j'aimerais remercier ma très chère amie, le docteur Wassila Taha, pour son invitation et féliciter tous les organisateurs pour cette belle réunion, particulièrement le docteur Rachad Bishara. J'ai beaucoup apprécié la présentation du docteur Loskort à propos de l'utilisation de l'ACOS dans le traitement du VARIS. C'est une technique séduisante, innovante et qui a démontré son efficacité avec moins de mobilité par rapport aux autres méthodes thermiques. J'ai cependant 3 petites questions. La première concernant les suites de la procédure. Faut-il prescrire une compression élastique, un traitement anticoagulant, un traitement anti-inflammatoire? Deuxièmement, le recul de ces procédures, semble-t-il, c'est un recul qui est encore insuffisant pour juger l'efficacité à moyen et à long terme de l'utilisation de l'alcool. Et troisième question, par rapport au coût de la procédure, comparativement aux autres méthodes thermiques, est-ce que c'est un coût qui serait plus élevé ou pas? Je vous remercie.
Tout le remerciement, c'est pour vous, Professeur Frikha. Dr. Boscourt, did you get the 3 questions?
I can't read.
They are on the screen now. The first question concerning the post-procedure. Does it need compression? Does it need anticoagulant and also anti-inflammatory drugs? This is the first question. Second one, concerning the recurrence rate. And the third one about the cost. It seems it's more expensive than the other modalities.
Right. The first question, definitely we don't need a compression after this procedure. If we do miniphlebectomy in the same session, in some patients, I still like to do miniphlebectomy in the same session. Yes, I do compression, but otherwise I'm not putting these patients on varicose stockings. And we don't do routinely anticoagulation for those patients. In some patients, for example, obese patients, a history of deep vein thrombosis or any thrombotic event, in these patients we do. And very old patients, for example, over 70, 75 years old, yes, I do recommend some sort of enoxaparin or something like that for this patient, but we are not using routinely. We don't usually need anti-inflammatory drugs after the procedure because it's not a painful procedure. The second question is about recurrence rate. In our series, the recurrence rate after 2.5 years was 5%. I don't want to speak anything about the 5 years takeover because, I mean, it might be a problem in the future. But, you know, believe me, 5 years recurrence rate will not be over 4 or 5% with using glue because it's really working very nice in the long-term wise. Price is still an issue. In my country, it's not. The reason is we have a full reimbursement for glue and there's no problem on it. But in other countries, yes, still glue is more expensive. The price is getting down and down, but still slightly more expensive. And this is a problem which, I mean, we cannot solve. It's a total industry-related problem.
Thank you, Dr. Bozkurt, for your replies. For the sake of time, we have to move. Professor Genassini will take on the question and answers. I'm sorry, there is only room for one question. Please go ahead.
Yes, and I'm sure that our honorable speaker will be available to answer to the questions eventually during the week, and we will report them in the website so everybody will get his or her own answer. The question is coming from Azat Shinalievi. Is it possible, Corset, to use venous glue for post-phlebitic syndrome?
I mean, what's the post-phlebitic syndrome? I mean, yeah, if you are talking about, for example, post-phlebitic syndrome in one of the deep veins, definitely it's a same strategy for thermal ablation. In some patients, definitely, despite long-term post-phlebitic syndrome, yes, we do use blockage of the superficial system. Depends on the circumstances.
Thank you.
Thank you. And now we are moving to the last part of this webinar. It's my great honor to present Professor Willie Kai, who is professor at University of California, Davis Health, and also he is scientific director at VWIN Foundation. Unfortunately, he cannot be with us, but it's my pleasure to pass on his word.
Rashad Bashara and Dr. Wasila Taha for inviting me to give some comments at the Saturday Night Vein Talk. It is a pleasure to serve in this role, and I'm certainly honored. Two great lectures from both Dr. Bozkurt and my good friend, Dr. Raghu Jindo. For Dr. Bozkurt, I believe that certainly you're a newer expert in terms of glue procedure. We know that there are 3 commercially available glue that's currently out there in the world. The efficacy is certainly very comparable to the current standard thermoablation therapy. But one thing I want to precaution the audience is the incidence of hypersensitivity with Kathy Gibson, based on her group, that she had reported about 6%. But we do not have much data on the very close group nor the veno block group. So certainly hypersensitivity most likely will have to be reported in any future studies. As far as Dr. Jindo, again, a very great lecture. Certainly I've heard this lecture before with the comparison of the MoCA procedure. The 2 currently available MoCAs are the Clear Vein and the Philbograph. Again, both has proven comparable efficacy to thermoablation. Certainly, we do not have any longer-term outcome study based on what Dr. Jindo had presented. But today, I certainly have learned something new about the Raghu Jindo technique. And with that, I will end. Good morning, good afternoon, good evening, wherever you are. Ciao.
Thank you, Professor Tai. And
Ciao.
Now I would like to present my dear friend, Professor Oscar Puttini, who is past president of Argentina College of Venous and Lymphatic Surgery. He's past president of Latin America Venous Forum, and he's a close friend. Please, Professor Puttini, go ahead. Oscar, are you with us?
Thank you. Good afternoon, good night, and welcome again to a new edition of this LATAF. Something so special for us. There are many webinars this day, but LATAF webinars because they are not only an opportunity to learn among experts,
Dr. Oscar, can you please?
Because they allow us to bring a message of unity between such distant regions. LATAF webinars make possible despite the distance until we can meet in person. Looking forward today, then this through a scientific and educational bridge that is LATAF.
Thank you.
Thank you. Thank you. And now, Dr. Wasila has another little surprise for us. Go ahead, Dr. Wasila.
Yes, Dr. Rashad, we have another surprise to celebrate another birthday, this time for Professor Lorenzo Tessari. Professor Tessari doesn't need any introduction. He's the godfather of foam, and we are all over the world following his steps for foam sclerotherapy. Bon compleanno, Professor Tessari. And very nicely and kindly, he delivered a short speech for us for LATAF night.
Dear all, I'm beyond honored and delighted.
Sorry.
Dear all, I'm beyond honored and delighted and receiving your kind attention toward myself. Thank you so much for the birthday wishes, and even more, thank you so much for having given as a present to all the world the best example of the best phlebology and lymphology teaching in a perfect time work between continents. This is exactly the spirit my mentor Glauco Bassi, founder of the WP, taught me, and this is his deepest hope, the present and the future phlebolymphodology, a productive moral time work addressed to the improvement of patient care and international professional synergy. Once again, congratulations for the LATAF outstanding initiative and a virtual big hug to all of you, until the time in which we will meet again in person. Thank you so much.
Thank you, Professor Tessari, and happy birthday to you.
And now to conclude, please, Dr. Wasila, present our guest of honor, Professor Said Mallah. Go ahead.
And now we introduce one who doesn't need any introduction. We are really delighted having him among us today as a guest of honor, Professor Said Al-Mallah. Professor Said Al-Mallah is a professor of vascular surgery at Wafaa University and president of the Vascular Society of Egypt from 2015 till present. And this is a wonderful occasion to thank him very much. I'm deeply thankful, Dr. Said, for giving me the honor to represent the society 2 consecutive years, 2018 in Melbourne and 2019 in Krakow. Thank you very much, Dr. Said Al-Mallah. And now the podium is yours to deliver your words as a closing ceremony to our night today. Professor Said Al-Mallah, the podium is yours now.
Thank you. Thank you, Dr. Wasila, and very thanks to Dr. Rashad and all the team of EVLA. I really enjoyed the scientific talks, the 2 scientific talks from great professors, and the discussion was very nice and very fruitful. As an Egyptian, I am very proud that this webinar is conducted from Egypt. It is, every Egyptian has to be proud that this is what occurs. I hope that EVLA will help and put Egypt in its place which it deserves. I also hope that EVLA can help all the vascular sciences in Africa and in Egypt. Thank you very much, all the team of EVLA, and I hope all the success for the next webinars. Thank you, Dr. Wasila.
Thank you, Dr. Said. All the thanks go to you, Dr. Said. Thank you very much.
Thank you very much.
I'm really honored having you among us today. Thank you very much, Dr. Said.
Thank you.
With this, we come to the end of today's webinar, but we cannot really leave without thanking our sponsors, our main sponsor, Servier, our gold sponsor, Medtronic, and our support sponsors, Abbott, Biolitech, and Promed. Thank you to every one of them. And of course, thank you so much to our honorable speakers and our esteemed panelists. We are very grateful to every one of you, and we hope to see you next Saturday, 6 p.m. Cairo time.
With the ultrasound, the big day of ultrasound and IVUS. See you next Saturday. See you next night. Bye-bye, bye-bye. Thank you, thank you.